within our environment. Some of the data has been extracted and is staged in the research data warehouse, but then some of them might not be. But our team could do consultation services and help you to obtain such data as well. We have integrated registry in the research data warehouse. Some of them are, for example, the tumor registry is an example. The hospital-based tumor registry data has been staged and integrated. So there are a couple of registry that exist. There are a couple of registry that exist in the research data warehouse. There might be other that we could work to link them together for EHR linked data analysis. We also have affiliated healthcare facilities based on our expertise with our data-driven clinical research informatics services. We are open to have a collaborative consultation for the population that might be coming through a couple of our affiliated healthcare facilities, and there are possibilities of interaction and making arrangements for either identifying patients for your clinical trial, clinical research, or there might be even possibility of bringing EHR data for your research as well, if there's a population of interest that you might have. We do have some informatics capability that I would consider to be advanced, somewhat robust as well. In an integrated environment within the institution that crosses the bridge. So the I2B2 technology that we have in conjunction with the data lens application that covers our population from the UAB EHR. It does help you build queries to identify a cohort, to discover a cohort, but at the same time look into the summary statistics of the cohort, also extract data in a self-service manner, or submit request for an analyst to help you to extract the data for you. Feeders is an application that was built for supporting NLP-based phenotype detection and cohort discovery, and that's a tool that's very helpful if you are needing to identify a cohort of population for a creation of a registry or for recruitment of patient, where discovery of the cohort based on structured data might not be enough. Right. And also, our team has collaborated with the research computing to create a pipeline process where data can be loaded in the research computing environment, which would be in compliance with the requirement of the data security for the patient data, and you could do advanced analytics, AI, machine learning, and even LLM-based research there. When I say LLM, it would be the open source one that could be loaded within that environment. It does not cover the API-based ones such as ChatGPT. That would be a separate conversation, or like the public cloud-based LLM. That would be a separate conversation. Also, natural language processing capability for projects needing NLP support. So both self-service and analyst-supported data access are being provided, and that's helpful if you want to do self-service within the capability. You can get data actually within a few minutes. I say few minutes, actually you get data immediately, sometimes in a second, depending on the size of your data. So if you want to do self-service, you could do I2B2 cohort creation, and also look into the self-service summary within the application called I2B2. If you need more data, then it might be either limited data set, and if it is limited data set, if you want the standard limited data set, that we have a data builder within the data lens application that you could select those cohorts, select the data tables on the cohort that you created in I2B2, and you could obtain those automatically generated limited data set through the data lens application. You have to finish a couple of the steps within the institution, acknowledgement, and you have to have IRB training. There are some governance requirement, but once you fulfill that, you should be able to get the data in a self-service manner. Or you could work with one of our analysts to define your cohort and obtain the data. It might be the LDS, a limited data set, that are defined under the auto-generated self-service. So analysts can also help the same way you could do by yourself, or if there's additional data needed, analysts can help as well. And if you need protected health information, that you'd be working with an analyst for sure. That can extract patient identified information if you need for any research project that requires those identified information, either for record linkage or for patient recruitment or any interventional project. I have been showing the number along with the chart to show you that that has been an active service, and our team has done a wonderful job in terms of supporting so many data extraction. And we have observed that a lot of people are interested in getting the help from the analyst, but we encourage you to take advantage of the self-service component, or at least start with the self-service component, so that you can obtain some of the data component of your data quickly. There are informatics clinic that is available to you, where you can meet with one of our analysts during that session. It's like a walk-in office hour where you can get consultation as well. And if you need more further consultation, we're happy to meet as well. So as you see that UAB does have a strong capabilities in terms of informatics services, data extraction and tools, and other capabilities. And that actually led to engage in national data sharing frameworks. Now, one thing I did not disclose you, I'm in this institution from June of this year. And I come from the University of Missouri prior to that. And I was highly engaged with the PICORNet. I was a site PI, and I've done, I led multiple PICORNet enhancement initiative as well for the Greater Plains Collaborative Network. A comparable one is the One Florida, where UAB is a member. PICORNet does have 8 networks. So Greater Plains Collaborative was one of the network that I come from. And One Florida is another one, but it's a similar network. There are some differences in terms of the network operation. So after moving here, the PI, Mike Mogavero, actually picked me up as a co-PI as the other site PI left the institution. So I'm highly engaged in the PICORNet. But we'll talk today about all of the networks and a little bit of deep about the PICORNet as well. So there are 2 kinds of networks that we are participating. One of the category, you'd see the federated network. That means data stays in a federated manner. So every sites keep their data. PICORNet itself is considered to be federated, although One Florida has the central model. So you can consider this to be hybrid, but I did not put like one in the middle. In general, overall, PICORNet is a federated network. It's a nationwide network that has about 78 institutions under the umbrella of 8 different networks. On the other hand, ENACT is enabled by a technological shrine, which is a technology was built on the technological I2B2, and it is powered by the National Center for Advancing Translational Science, the NIH Center, where all the CTSA award is being funded, and ENACT has been a function of that framework, where a distributed coding can be done over this Shrine network, and UAB is participating in that as well. Trinetics is a network created by a for-profit entity, named Translational, and it brings a lot of tool set on the data. I think it has over about 111 institutions. Actually, they call this healthcare organization, 111 healthcare organization, including University of Alabama, Birmingham. RC is like more collaborative. So we'll talk about this a little bit as well, what kind of resource it brings to you. On the other hand, the centralized networks or the data enclaves that you could consider, NIH, all of us research program, I think it had the initiative for 1 million cohort. I think they're pretty close to 1 million, but many institutions recruited patients into the cohort and brought data from different dimensions. Emerge network, I think, brings the strength from the genomics angle in the data set, and it has over 100K patients there. The N3C, on the other hand, the National Clinical Cohort Collaborative, if you might know about this, the National COVID Cohort Collaborative now changed to National Clinical Cohort Collaborative. So now it's evolving from the COVID cohort to a clinical, like the EHR-based cohort, and it's going to be a centralized enclave as well. Epic Cosmos, upcoming, as UAB Medicine is migrating to Epic Cosmos. Migrating to Epic. Cosmos is a centralized national, it might be international database that's going to bring access to over 300 million patients EHR records. So lots of opportunity out there. Let's move to the next slide to talk about each of the network. So in PCORNet, it is representing, I think it's representing over 60 million patients, but they estimate that in any given year, it's about 47 million across the US each year. And you see the density graph out there to show that despite the number of institutions that participates in bringing the population to represent in the database, but also their electronic health record data, it pretty much covers every corner of the country. Density is not adjusted based on the population within the state, so it's going to be heavy on the east and west side as our population density is similar, but pretty representative. These are the institutions out of the 8 networks. There are about 78 institutions that is participating under different network umbrella, and you'll see one on this. You see University of Alabama, Birmingham, the number 36 under One Florida Plus. It's called One Florida Plus because it started as a One Florida, only the Florida institution, and it has expanded to include institution from the one on the map, the purple one. So UAB is one of them. That's from Birmingham, but they also have one from Arkansas, and they have one from California too. And then they have number 30 is the Emory University, so from Georgia. I think they also have on the north 41 is University of Minnesota. So you have the opportunity to work with one, like our own network, One Florida, or beyond One Florida to work with multiple institutions. We recently wrote a proposal, CHAP guides. I'll give an example of that, how we worked with multiple networks, and we were able to recruit of pretty much all the members from 4 networks to bring large cohort into the analysis. Technically, if we could afford, we could go recruit more, because there are other institutions from other networks also showed interest when we did the webinar to the network to recruit sites. PCORNet brings a common data model. That's the strength. It does empirical data characterization, data quality check. It's a quarterly process. I told you I will try to keep you 50,000 feet level. So all the sites will represent data in one common format. So that's the strength. We could do central analysis, bring the data together, put in one single bucket to analyze it, or we could do distributed analysis, depending on the kind of governance and data sharing framework that you would like to exercise. So it does require some consultation, some thinking through how you are going to bring the site data together and conduct the analysis. But the strength brings all sites are being representing their data as one single common data model, one single common representation of the data with standard terminologies and vocabularies. So it's pretty standardized, have common technological platform for execution of your queries. And the network operation over the last 10 years, I would say, has been pretty successful in terms of operationalizing study queries, extraction of the data, recruiting people, all the activity we do around data related to a study, regardless of observational, retrospective, or interventional, or prospective or observational prospective studies. So we talked a little bit about like One Florida is a PCORNet network. So you see the listed organization on that network, and it has the map of One Florida. It's representing over 23.4 million patients within their enclave. But they have some key features in that network may not exist in other networks. So those are like additional features beyond what is common across the network. So link to census tract, sites with linked healthcare claims, Medicaid. So that's an interesting one if you're interested, Medicaid plus EHR data research. A linked tumor registry. So like we talked about linked tumor registry at UAB, but then this network for all of the 23.4 million patients, if they have a cancer cases and exist in the registry, in their hospital registry, that are being linked. Patient can be re-identified with IRB approval. What does that mean is every sites are keeping their identified data, but there's a linkage being maintained. So that means it can help identify patients for sending out surveys, inviting them to participate in studies, doing consenting. All of the thing can happen within that framework. There's the ongoing work on the mother-baby linkage data. That's the key thing that we utilized in that particular proposal that I was talking about. And then One Florida does also have natural language processing capability as well. ENACT, on the other hand, is a network where it's powered by the NIH NCATS, and you see the distribution of the sites that is on this map. Pretty much, some of the sites might be overlapping. I think many of the sites are overlapping with PCORNet, but there might be sites who is not participating in PCORNet. That does give you access to the EHR data, electronic health record data. So population is coming out of those organizations' healthcare system in a federated manner. You can do a query like I2B2 if you have used I2B2 in the past. A similar query you can build using the Shrine technology. And you can actually send the query to all of those institutions and see institution by institution cohorts. So you can identify the population. But you could also extract EHR data in an enclave. It's a recent addition. I would say recent is like I think sometimes starting last year. This enclave does help you to request for EHR data on those selected cohorts to be deposited in a computing environment for you to do advanced analytics, machine learning, AI, statistics, statistical modeling. It depends on your study design, but it does have this capability now. But you have to work with the network leadership to follow the pathway. And there's the intake form actually on their website that you could start with and then guide through the process to get access to the environment. Translational is one of the for-profit entity. However, we participate, and there are lots of organization participate. They does represent 250 million plus patients. They had 3 webinars yesterday. I joined those webinars to see what kind of capabilities Translational have. It is pretty rich, I can tell you, comparing to many of the tools that we can bring along with the data. And it does help you to do a lot of self-service data analytics beyond summary statistics. And you could use that for UAB data within that platform, but also request data from other healthcare organization to contribute to your research. And I think they have a fee-based mechanism depending on funded activity, unfunded activity, but it will need to be discussed with Translational once you get access. But it does give you a very large number of population. Given any cohort, I can, even for probably rare diseases, you probably are going to have enough power to do a robust analysis. All right. And they have interesting data domains as well, but since it's a platform driven approach, it's distributed, but they can, if the data exists within an organization, they can build a lot of new features. So as you see that they have calculated features like EGFR or BMI. In many databases, the BMI will be populated from the EHR, and for a lot of the patients, height and weight might be available, but the BMI was not calculated, especially for adult population, right? It's calculated on the fly in the EHR for the physician to look at, but it is never recorded as a BMI. In a research study, you have to calculate, and you know that with adult patient, oftentimes height is not taken, only weight is taken. So how do you find the height? So one of the most recent visit, so that's an interesting algorithm you have to do, but they are calculating this for you. Just wanted to show you, but they have interesting other data set as well, like third-party data link. They're saying that they are linking claims data, they're linking social determinants of health. I think it's area-based linkage probably. They have algorithmic enhancement or enrichment to the data as well. So that's another interesting one that we have a premium access, I would say, because we are a member. Many institutions would not have. Actually, University of Missouri did not have access to Trinitex when University of Missouri never participated in that network. ARTC is more collaborative. They don't represent like a data sharing network. It does not have the framework beyond the common data model and the tool set, but it does create the common data model. And University of Alabama, Birmingham is creating, our CRI team is creating and actively maintaining the OMOP common data model. So if you want to design a multi-site study, including UAB data, you could recruit sites, you could find, identify sites who represent their EHR data in OMOP common data model, and you could have a common playground to design your research study using one common data model representation like the one I showed for PCORN. It also has the standardized vocabulary, which they call Athena. That means you would be using Athena in your research design as you analyze OMOP data, because each individual institution will be using this standard mapping in the OMOP common data model, which is different than the PCORNet common data model. PCORNet does not have a standardized vocabulary like this, but it uses the industry standard vocabulary. That means if diagnosis codes are being represented at ICD-9, the ICD-9 will be captured. If the diagnosis record is coming as ICD-10 record, it will be captured in the data, but it will also tell you that that particular record is ICD-9 or ICD-10. If it's a lab results and has a lab line code, it will tell you which code it is and which terminology, which is LOINC in that case. But in OMOP, the concept ID is being coded, so that you will be using Athena as part of your research design process as you identify the codes to be queried within the OMOP common data model. Let me check my time. So we're halfway. Let me see if I can get done rest in 20 minutes. N3C participating sites are also, you'll see like similar dots, like a lot of the institution from the east and a lot of the institution on the left, but many institution from the middle of the country as well. About 84 sites, over 28 million patient population being represented. But I believe that now they're moving from COVID cohort to clinical cohort. And if all the institution actually contribute all of their EHR data, or like entire population beyond the COVID and COVID-related disease population. If it is entire EHR, I think it's going to hit to probably over 60, 70 million people. UAB is a member of the network. We do contribute data in that network. It's a central enclave, and they have this governance process where you could go through the process to get access to the data. All of the network I'm mentioning, some of them might have a fee-based structure for certain projects that you do. So just be aware of that. So some activity beyond accessing data beyond certain level of activity might require bringing funding for doing your projects. For example, N3C is a central, they have computational cost, and a project might have a heavy compute proposal. Someone has to pay for that. That's what I mean here. NIH, all of us, they recruited so far over 869,000 people. And I would not go very much detail into it, but UAB also contributed population recruitment and also contributed EHR data and other kind of, I don't know the exact UAB's intervention that we participated, but I'm sure that we contributed data in multiple of those domains. So every, like the patient's EHR data is being brought into the picture. So their data model is the OMOP common data model that is used, but it also has genomics data and also measurements and wearables. So physical measurements and also Fitbit data as well. Like Fitbit, they have 60,000 patient data. So if you're interested in doing research with the mix of EHR data, wearable sensor data, physical measurement, or even genomics, if you put like all the criteria, the number of patient record may narrow down to a smaller cohort, but multimodal study is possible here. That's what I'm alluding to. Surveys, some of the patient have interventions, and then some of the participant might be in a project recruited through where it might have intervention, or it might have survey study design. Those data survey results are also incorporated into those databases. All of us has this centralized database with the data access. It's called, I think, All of Us Research Workbench, where you have to request access, and institution has to complete some documentation, which probably in place right now, and you could go through the process for getting access and do the analysis within that workbench. I think it is in the Amazon Web Service cloud. It gives you analytical workspace, a set of tools, data set builder, cohort builder, and using those tools like R or Python, you can do any kind of analysis that you want. I think they're saying they're supporting R, Python, SAS, including Jupyter Notebook, RStudio, if you use any of those tools. But the bottom line is you can get the data within your workspace, within that enclave, that cloud environment, and then you could use those tools for analyzing data. So it's a pretty robust environment for you to do so. Epic, once we have this in place next year, I think sometimes mid of next year, that's what we are anticipating, would give you access to over 300 million patients. As you see, over 17 billion encounters. And it does represent a pretty wide range of population. You see the race distribution, but it brings a lot of data, even minority races as well, as since it is a large representation of population. More to come probably next year as we have access to that environment and we roll it out for access to our investigators. But I would say it's a huge opportunity that is coming to our door. Comparing the network functionality, I don't have all of them. This one is coming out of one of the PicoNet analysis that they have done. As you are doing research, you're thinking about, can I identify population? Can I see feasibility of my study? So you can do feasibility query in different network, has different capabilities. Identifying patient population, for trial recruitment, some of the network may have this in a strong capability. Some of them might have loose capability. They can do it, but they don't just simply have the entire framework and operationalized for that purpose. Coordinated data curation, it's Piconet is distributed network, but they does pretty good job. But some of them are central network and they just do their curation by themselves. They don't necessarily go back to the site, say, hey, you have to fix something. So if it's a central network, it would have that limitation anyway. Like couple of the, or even in a distributed network, it may not exist as a operationalized function within that network. Connection to patient and providers. So after know the data, know your people, can you recruit people? Can you engage patient in your research? Can you engage providers in your research? Can you recruit them in your, is a question. As you see, some of the network has robust framework for that. I would say Picornet probably is an outstanding one if you are doing pragmatic clinical trial. There are a lot of study happened so far using the network that has been advertised to the Picornet website as well. All right, let's move to some of the discussion around data management for large-scale network operations. So GPC's approach, when I did a lot of work on that for performance and scalability, information security, interoperation with other data, like data status, interoperation with other research communities. I wouldn't go into details of all of the thing it happens there, but I did presented that enhancement work that was funded by Picori, and I was leading that effort for the Greater Plains Collaborative. Every Picornet network was doing that work, but our approach, I will give a little bit of sense. It was Snowflake based, so we have been working towards migrating from file sharing based to direct sharing over Snowflake. So if a site has that capability, they can do that in that particular red box that you see. But then currently, many of the sites have been doing file sharing based, like they have to manually upload, and most of the network do this, but we have been working in that particular enhancement before me moving to UAB, and I think it's still an ongoing work that sites adopting Snowflake or have some sort of access to Snowflake where they upload the data, but then data sharing becomes seamless after that within the network, but then that sharing would still remain federated. That's the point here. In that framework, we do a secure view-based consolidation of the data. That means data will not be replicated into a central database. That's a virtual merging or linkage of the data, but data remains each individual data sources for each individual institution's node. And we also do the similar approach for mapping, a virtual mapping to I2B2 data model. So there's the Picornet to I2B2 data model harmonization so that network folks can query I2B2 data, and that currently exists. Atlas has been piloted, but I do have an example of research that one of my postdoc did that I'll show you. Atlas toolset is from the RC collaborative community, and it does give you the opportunity to do research with advanced analytics, where you finish the create the analytical package using the tool. It does generate an R package for you, and then you run the program to generate the results and you interpret them. That pipeline was not completely seamless. It has some complexity around it. And as I was telling you that I was watching the webinar yesterday for Translational, that one seems to be more seamless than the Atlas one. But Atlas is an open source tool. Any institution can adopt it. Translational is a proprietary one. So only if you're a member of Translational, then you can only get it. So Atlas was implemented the similar way. We do provide analytical environment like the one we have been talking about for all of us. It's a similar environment where data can be extracted on your research study, and you can use R, SAS, Python, or other advanced technologies that in that cloud enclave. And we also facilitate a mechanism to extract study-specific data in a AWS S3 bucket or Snowflake. And that can be used in conjunction with the analytical environment to finish the analysis. Now that's the past thing for me, right? It was at the University of Missouri. I just wanted to show you that for a large-scale data management operation, how we can build seamless technological infrastructure by reducing the infrastructure optimization and management, by optimizing the infrastructure, by reducing the operational management, but focus on the innovation. So that was one of them. That environment, it helped us to reduce the storage significantly. That does help a faster query retrieval, and we have seen up to 18 times query data storage compression using one of the tools, which we call Snowflake. Data querying and doing analysis using large scale data is a big issue. So for example, for the data curation, you see that some of the sites even ran queries for over more than 30 hours, like a couple of days. So even for a CDC COVID project, we have heard that sites might have to run queries for longer time. So that has become an issue in that PCORNet enrichment initiative that I was leading for GPC. We showed an approach that without even changing much, but changing the hosting kind of environment, we can improve significantly without changing any of the query itself, like it is being written in the SAS package. Now, even within SAS package, you can optimize the query that works much better with that particular technology. Like SAS has a Snowflake connector that has optimized process to convert the SAS program to run, convert this to SQL program to run within Snowflake, where our epidemiologist can write the program in SAS, and the data will be executed in an optimized way within the database environment. So as you think through some of those, fine-tuned processes, as you are thinking about doing the study nationwide, the kind of framework that is needed to build this kind of framework, I would say having advanced technological framework is really beneficial to win some of those national funding games. So done 2 system demonstrations out there. One for, for I2B2, one for the RC Atlas. A similar framework, distributed concept, where data remains federated, but it still can be queried and analyzed through this central platform. Harmonization is one of the things I presented you, that there's a OMOP common data model, there's a PCORNet common data model. In that work, we have done some dynamic harmonization of those 2 data model. If you're bringing data from sites who may not have both data model, like UAB is doing OMOP, but our data is being in PCORNet common data model generated by the one Florida in the central. We are trying to host the data in our environment or eventually generate ourselves. So what I'm pointing you out is many institutions may not have that kind of like multiple data model being represented. So if you are bringing the data together, you are looking at harmonizing the data. So I showed you PCORNet to I2B2 harmonization, PCORNet to OMOP harmonization for these two different work that we had. But other institutions have done the harmonization bit from OMOP to PCORNet, for example. So there's a bidirectional harmonization technology exists. It may not be fully robust, fully vetted, fully done kind of thing, but it gives you a good, quick jump start to start with adopting those technology and get your project done. Otherwise, you have to create the same data analysis package for each individual data model, or you pick and choose the sites who can contribute only one single data model, which is common. So you see, it's like a shopping cart, right? You have to think who has what kind of capability. But if you can do the data model harmonization, then you don't have to worry about which site to pick. You can bring any data together and harmonize that. So I believe N3C have done the work, and I2B2, if a site only have I2B2, they can contribute to I2B2 data. If a site has PCORNet only, they can contribute, and the OMOP, and then I think everything is being harmonized into the OMOP common data model. So that's the harmonization. It was done in that kind of network like Anthracic. So as I was talking about this, in that particular Atlas deployment for the Greater Plains Collaborative, data remains federated. There's a harmonization approach. And then after that, the data can be queried through the Atlas. Even the data is fully federated and distributed. So federated and distributed network can be built and toolset can be deployed in a central manner where data can be accessed, but facilitated through a technology like Snowflake. So we demonstrated the utility of the Atlas tool. I would not go very much in detail, and I probably have to cut down some of the slides to finish in a few minutes so that I can take questions. But a slide deck will be shared to Amy, and we can share with all of you as well. In that example, we use the Atlas user interface to complete the analysis, download the R, generate the R package, and download the R package, and execute the query. But the entire study design, including cohort identification and the kind of analysis we want to do, was done in Atlas. And here we are looking into the herpes simplex virus type 1 and its association with dementia outcomes. And we did found the correlation. It's in preprint right now. I have this screenshot out here from the preprint. But I wanted to point out the fact that this kind of analysis tool does bring a lot of capability for investigator to conduct research without dealing with a lot of the technological barriers or programming barriers for finishing an epidemiological analysis or AI machine learning project. As you're thinking through the methodological approaches for solving large-scale data management issues, there are a couple of papers that I listed that that I'm an author in it. Line document ontology mapping for clinical nodes discovery. Clinical nodes de-identification is needed for nodes project. CMS record linkage with multi-site EHR data. So that solves your data completeness issue on certain population. That was an interesting paper that we did on the Greater Plains Collaborative Network. Data enrichment with patient-level social determinant linkage from consumer database. So it's in preprint right now, but we can do the area level ASDO. The other one, the consumer database one, cost you money. But UAB does have a ASDO core. I think Gabriela is on the line, and I've seen that there's a wealth of data resources that we have on either patient-level linkage or area level linkage that we could do. So in collaboration with ASDO core and our CRI team, I think we can facilitate geocoding based linking or patient level linking on social determinants of health, economic, environmental variables that can help you do research in that space in conjunction with the data coming out of the electronic health record. Privacy preserving record linkage might be needed. I put the paper from the PCORNet Coordinating Center led initiative to demonstrate the patient linkage across all of the 78 institutions within PCORNet. If you want to stay completely federated using the concept of federated mining and transfer learning, you could do distributed analysis without bringing the patient level, row level data, which is going to share summarized aggregated statistics that would reduce the burden of data sharing agreement, IRB, and other issues. And there will be an upcoming talk announced from our department. I think someone, I forgot the name of the faculty coming from Auburn University. I think that person will be in person giving a talk about federated mining as well. I did list two of my publication, but that talk might go into very much detail into the concept of federated mining and how it might apply on the healthcare for distributed analysis. So I was talking about the CHAP guides. I think I'm doing pretty bad in time. So we have 7 minutes left. So let me wrap up in 2 to 3 minutes. UAB-led distributed analysis through PCORNet. That was a recent proposal, but we were able to recruit. We needed that set of variables on So the population requirement in the RFSA is nationally represented population of pregnant women with chronic hypertension receiving care in various clinical settings. And the project was to show that there's a guideline for chronic hypertension management that Alan Tita and Rachel have done a clinical trial in the institution. Now we want to do a real world evaluation of the uptake of the guideline. So how we do this? So we need electronic health record data. That's the best source I can tell you that we can obtain for doing this kind of evaluation study. So that was a perfect match. Since we are one Florida Plus, we are PCORNet, we picked up that particular route, and we successfully reviewed the fact that if the kind of data we need will be available. Interestingly, the patient relationship table, that new initiative within PCORNet, is going to give us the mother-baby linkage. That means we could look into the neonatal outcomes and also the baby the birth outcomes in terms of neonatal outcomes as well, to see if there is any risk or any improvement in those outcomes since the CHAP guides the release in the last few years. We have recruited sites from those states, but you saw the PCORNet graph. Despite recruiting sites from the state, their EHR does represent population coming from across the entire country. So I think we're going to have a pretty good coverage. Hopefully we get funded. NIH Recover is another example. That's the recent publication. Actually, it was interesting findings, I believe, and lots of news media actually picked up the article. I was one of the co-author, but the finding is to show that in a national cohort of EHR data that long COVID does exist even with children, and it's a serious matter, right? So we should not be probably forgetting about COVID, even from policy perspective. But you see, this kind of research project is feasible because of this national data sharing framework that exists either in a central enclave or in a distributed manner. That was one of the study done by one of the UAV investigator team, but it was more about comparative effectiveness research using Chinatext, and they were able to compare thyroidectomy with other medical and RAI therapies for lowering the risk of cardiovascular research. And they were able to look into over 160,000 people in that particular cohort. So large scale population, national, international population, and you can do a lot of interesting, you can validate a lot of interesting finding. You can do comparative effectiveness research. You can do outcomes improvement research, observational or by recruiting patients as well. So I'd like to thank you for listening to my talk. I would like to acknowledge my students, postdoctoral fellows, and collaborators, my prior team at the University of Missouri, NextGen BMI staff team members. We also have a similar team here within our department, the Clinical Research Informatics team that does similar kind of work, and I'm glad to be at UAB, and I'm looking forward to your comments or questions. Thank you.
Thanks for the great presentation. I've just put the, thanks for also advertising next week's PowerTalk. Actually, that happens to be next week. So I put the link in there and the name of it and how you can register for that one. So, it's interesting to, I'm very familiar with how we have all the data resources and federated models here, but you've been at these other institutions and also been involved in on a higher level. So it's good to see that perspective. So I appreciate that. We're at time, or we have 2 minutes. So if there's anybody have any comments or questions, please feel free to unmute yourself or put them in the chat.
Jim, go ahead.
So I just want to say, I'm sorry I'm late, and thank you for doing this. I had a meeting with the dean's office that ran over, and so I'm going to watch the recording for sure. Although I think I know what you did before you got here, which is why you're here and doing great things since you got here. So again, thank you for filling in at the last minute also. It's very much appreciated.
For the rest of the audience, I was requested last week if I could fill in. Someone canceled, so I put together the slide last few days while we have been working on some of the other CCTS angle work. So I appreciate any comments, question, even later on. Happy to meet with you to talk about your research ideas, to see what are you thinking. Is there any opportunity for collaboration, or any way, regardless of collaboration, right, can help you to drive your research project and win some grants probably.
Other comments or questions? I guess we have 1 minute left.
I have a very quick question to Dr. Mosa. You commented on the Cosmos, the EPICS. When you submit a query to the Cosmos, is that institution specific, or it goes across all the other institutions? For example, if you want to do a survey of a pathology diagnosis or something like that.
I believe we would have access to the entire repository. There might be certain terms. We don't know the very much detail about how to operationalize that, but working with our colleagues in other institutions, I believe, participating institution, the members from the participating institution does get access to the entire population.
Okay, how granular that would be? That would be
okay. So your question is how granular, right? So think about the EHR data. So it comes like at the record level, patient level, record level, encounter level, time is stamped. Now in the de-identified database, the date will be shifted. We probably would know how exactly the data is being represented, but however, it would be pretty granular to the point of the fact that it comes out of the EHR.
Okay, thank you.
And that was my understanding about EPIC. I have not seen the data by myself. I assume that it's not different than the other data representation that is coming out of the EHR.
Yeah, I think the target date for pathology is sometime 2027, I believe, early 2027. So that's what we are thinking about.
Well, we're at time, so thank you everybody for attending, and thank you, Dr. Mosa, for the great presentation. And I hope that that this encourages collaboration and helps us with our own research projects.
Thank you, everyone. Have a great rest of your day.